a lady came with a child who died and came to Buddha and said, oh, you are a God man, and you have powers, and can you please, I mean, see, this child is a so innocent child, why the child should die, I mean, can you do something about this? Now Buddha told her, all right, you go and get some mustard seeds, I have to sprinkle on this baby, but get it from a house where there was no death at all. So, I mean, that drives the message. He was so practical that, nobody can get out of this life alive. Death is inevitable. Death is a thing which happens in everybody's life. It is not unusual. But what happens? It became a very emotionally explosive term now. Everybody starts fearing death. It's a very unmentionable quality of death. And the bottom line is the death in the hospital is always interpreted as a failure of the healthcare system. And the whole death pattern is changing now. Previously it was an event. I mean, during my great-grandfather days, maybe even grandfather days, it was an event. Now it is a process. Everybody goes on a ventilator. I was surprised that even in India, things, I mean, people used to accept death as a natural phenomenon, but I mean, 3 months back, I mean, the past president of India, R. Venkatraman, he was 90s. He was in the 90s, and he had multi-organ dysfunction, and they just hooked him up onto a ventilator for 3 weeks, and he died. I mean, things have, the whole pattern of death is changing because into a process and not an event. And, I mean, this particular thing about social death and biological death, we all were, we are used to a biological death. But people now go and just be on the ICU, they are socially dead. And then 4 weeks later, 8 weeks later, the biological death comes in. So there is a lot of changing pattern of death. And someone's death is rejoiced. And I mean, that is the other spectrum, other phase of death, which is absolutely, I mean, unpalatable in one way, but I mean, it depends again on the societal thought about it. And then let me ask you one question. This particular headline news says there were 200 murders. Let's assume that there were 201 murder on that day. For you and me, oh, it's a minor error, it's a statistical error. But for the person who died, the family who had the 201, the 201st person's family, it is not a statistics. So, I mean, what I'm trying to drive at is that, there is a changing concept of death between what is seen and what is experienced. And that is why I'm saying I'm not trying to provocate the people saying that, I'm insensitive towards, death in ICU. That is not the way I'm going to say that. But what I'm trying to drive at is we have to accept certain terms of nature actually, right? 4 doctors in US sat in front of TV and watched Chicago Hope and ER and other health serials, and they published a paper in the New England Journal of Medicine. I didn't think that it is so easy to publish, I mean, sitting in front of a TV, and actually this particular paper has been well cited, actually, Dr. DM and everybody, and they actually came out with the statistics as how the TV serials are propagating misinformation about CPR. And following that, actually there was a big drive. People went into nursing homes in US and said and gave them the stark reality of CPR and its outcome, and people actually signed do not resuscitate orders for them, because every single old person who was ready to die in the nursing home, they called the emergency department, the EMTs came and then jumped on the chest and then put in a tube and then hooked on the ventilator, and then two months later they die. 2 weeks later they die. So, I mean, in theory, anybody can be intervened that way. So they had to actually conduct a mass education program in nursing homes to say that this is reality of CPR, this is what it is, and actually many people signed the DNR order. And I have to tell you that the Society of Critical Care Medicine, when I went to receive the award, actually one of the founding members of Society of Critical Care Medicine was Barry Shapiro. He's a pioneer of critical care medicine. and he passed away like 2-3 years back. He said, do not put me on a ventilator. He had cancer. He went into his California beach resort, stayed there, and died peacefully. That's a dignified death. He is a pioneer of intensive care units, and he said, please do not take me to ICU. And what we are doing here, all incurable illnesses we are bringing, and we are just hooking up onto life support. And we all think that we can conquer death. You can see this all this Sarah Connor Chronicles and Terminators and all cyborgs, the cybernetic organisms. Oh, everybody think that with technology we can prevent. I was watching a Tamil movie where this superstar hero, he was beaten up and killed in the prison, and he'll be taken to some distant place 20 minutes away, and the doctor will be standing with 2 paddles, and he shocks, and this man wakes up coughing, and then goes and fights the villain. And that is how the misinformation is being transmitted. I mean, that is the problem with the current media. So I wrote this article in UV Today, where they were kind enough to publish this. And you have to know that 70% of the Americans actually wanted to die at home, but 75% die in the hospitals. At least 30% of them die in the ICU. And same thing situation in Canada. 70% of Canadians die in the hospital, and 50% of them die in the ICU. So I don't know. I mean, I used to give this to my students actually. I mean, think of sub-Saharan Africa. Every year, 1 million patients are dying after HIV. Now, if all of them have to die on a ventilator in ICU, think of the resource utilization. Is it tenable at all? It is completely untenable. We all started to think that, they have to be on a life support technology. And as early as 1995, the JAMA published this very, very popular article as Support, which is a study to understand prognosis and preferences of outcomes and risk of treatment. And they clearly said there was a lot of unwanted life-sustaining treatment at the end of life, those days in US. And that is where we are now here in Trinidad. So what are we aiming at? You all, I mean, Prof told that, we have come from the Easter. So, I mean, resuscitation by definition means restoration of the function of the organs, physiological function of the organs. And many European countries, anesthesiology is called Department of Anesthesiology and Reanimation, reanimatology. They even made it as reanimatology. So reanimation is a restoration of the function of the whole organism, not only the organs. But we cannot expect resurrection or a reincarnation. All that we have to aim is reconciliation with the nature. Now, that opens a subject called medical futility. There are plenty definitions, and it's a very controversial subject. The best definition I saw is again from JAMA. There is an Institute of Medicine IOM definition, but this one, in the course of treating a critically ill patient, at one point of time it may become apparent that any further intervention will only prolong the final stages of death or the dying process. At this point, we consider that that medically futile. That's one of the very, very versatile definitions I came across in the JAMA. Now, authors have tried to conceptualize futility. If we remember our case 1, which I told you, they were giving 50 times the dose of the drug, and it was not going up the blood pressure. Okay, he had 3 or 4 cardiac arrests. That means it was not doing the intended physiological effect. And the second patient, we knew that the patient will die before discharge, regardless of whatever you do. He had a massive stroke, massive bleeding in the brain. We still continue to, do that. The third one, patient had an underlying disease with cancer spread all over the body. It was not compatible with long-term quality of life. We can do something, but she was unresponsive because there was the cancer spread to the brain. She was unresponsive. So long term, we won't be able to do anything for their quality of life. So this is what we published from Barbados about futility of care decisions, and how what are the decision making process we have. And the dilemma of all the physicians is that there are the religious beliefs can influence the futility of care decisions. They don't want to take any chance. I want to support life. That's all. I don't care about your futility. Some people feel guilty that if I withdraw support, the people not only the people blaming them, but their own feeling of guilt. And then again fear of litigation again, and that is coming up so much. I was trying to tell yesterday in the TV that, you know, I mean, we have to move away from this thing, you know, because we have to have a rapport with the patients. And then there are a lot of other social factors. We found in that particular paper from Barbados that, you know, people did not want to discontinue treatment if one of the relatives of the patient lives in US. That was a social factor actually. I mean, they were afraid. Oh, his son lives in US, I don't want to disconnect. So that is factors, you know, people we used to encounter. So what do they call this? This is called, I mean, I wrote this in the UV today, and it's a very interesting concept. I mean, in the Greek mythology, the authors call this process of prolonging the life in intensive care as a Eos syndrome. Eos is the goddess of dawn, you know, I mean, she had a mortal lover, Tithonus, and she went to Zeus, who was the, you know, the chief of the gods, and said, "Oh, I have I'm badly in love with Tithonus, so I need immortality for him. He is a mortal." Okay, granted. So she came. She forgot to ask for eternal youth. Tithonus grew old and old and old and old and old, and she just dumped him in a dungeon and forgot him. Because he couldn't die, because he has immortality, but she forgot to ask him that he has to be, I mean, he has to be eternally young, which she forgot to ask. And this is exactly what the authors describe as, you know, prolonging the process of death. I mean, it is going on and on and on. Now, at one point of time, you know, even relatives start asking, "Doc, will anything happen?" You know, I mean, something like that. You know, I mean, when it goes beyond certain level, I'm trying to tell you, I'm not again trying to touch the sensitive issues, but again, you know, when it is going beyond certain level, you know, we have no control over it. And that is why physicians cannot do what nature does not allow, and should not do what professional integrity does not allow. And we are actually we are here to heal. That is a medical goal, and we cannot hope for miracles. And I want to just touch on the patient rights. You know, I mean, it's because there is a lot of confusion on the, you know, right to refuse treatment is often confused with the right to demand it. Okay, I mean, if a patient can come and tell me, "Do not touch me," that's a very well defined constitutional right. I cannot touch the patient. But the patient, I can give a variety of options for the treatment. They can choose. They have that right. But they cannot say, "Oh, you have this C-reactive protein, so I need that." I have to decide whether the C-reactive protein will be effective for you. I mean, it's not a well-defined right. I mean, because, you know, I mean, patients are not that well informed like a physician, and that is why there is this conflict between autonomy and paternalism. I mean, call it parentalism because, you know, they say, "Oh, you are a male chauvinist. Why cannot be a maternalism?" You know, so I will say parentalism. Okay, so autonomy is one which is practiced by, I mean, preached by the American ethicists. You know, they have these 4 pillars of ethics called autonomy, justice, beneficence, and non-maleficence. And many authors have questioned whether it will spread globally as easily as the Coca-Cola. You know, I mean, they are doubtful whether it is possible, because in my view, I have written articles that, you know, ethics should be taught and practiced in the context of the region where you practice. You cannot take ethics from US and apply here. It's good for exams, yeah, but otherwise I don't think it's practically applicable here. And even within the Western countries, there are a lot of authors who have a dissenting voice against autonomy. See, when a patient comes with that autonomous behavior, like in US, they come to a doctor. All right, are you sure about this? So I need this gallbladder surgery. I need a second opinion. I need a third opinion, because they have this particular mistrust to the doctor. They think that, "Oh, this man is trying to earn money out of me or what? So I will go for a second opinion. I will go for a third opinion." So when the patient autonomy takes dominance, it erodes the trust between a doctor and a patient. So there are a lot of authors, even in the Western countries, who say patient autonomy should not be the primary thing. There should be a balance. I'm not saying that there cannot be any autonomy at all. What I'm trying to say is that there should be a middle ground between paternalism and autonomy. Because in one way, if you see that, sometimes paternalism is being exploited. I know in many countries, including India, when the patients are completely ignorant of their treatment, the doctors exploit that. But not all of them, but there are errant doctors. So I'm not saying that paternalism is the ultimate, but there should be a middle ground. There should be a middle ground. You cannot say that everything I am the one to decide about me. Why did you come to me? Because now see, even in Caribbean, where there are many patients who come and tell me, look, you know better about it. You do whatever it is. I accept. That is the cultural context of it. The same thing I have faced in India too. Because, when they have the trust towards the doctor, and that trust has to be actually respected, and we should as doctors ethically conduct ourselves. Now, I am going to again be provocative by saying that, in a futile situation which I described, paternalism is well suited rather than autonomy, because ICU treatment is very advanced and complex topic. Even many of the non-ICU physicians may not be able to fully comprehend what is happening. And the well-informed physicians are definitely in a better position to advise the patients and the patient relatives that this is the condition of the patient. And many a times when we tell that the patient relatives, you decide whether the patient can stay on ventilator or not. Now they feel that, why are you transferring the onus to me? They feel guilty. It is my dad, my mom, so I can't take a decision. So what is your opinion? So that is another pitfall of having transferring the decision-making process to patient surrogates. So they feel guilty to take decisions. And actually courts have supported the medical the futility. I have to tell you about the statute and the common law, because as you all know, statute is something, a legal provision in the books, but common law is something defendable with expert witness. I cannot have a statute for how to do a gallbladder surgery. But if something goes wrong with a gallbladder surgery, the expert witness will call and they will try to defend whether something is there or not. And the same way, medical futility can be defended by common law. And in many countries of the English-speaking Caribbean, we don't have statute to withdraw life support, except in Trinidad and Tobago. And even in Trinidad and Tobago, this particular statute which exists to withdraw support is in the context of organ transplant. Organ Transplantation Act has something as you can withdraw the treatment. So if there is an astute lawyer, they can always say that, oh, did you harvest organs from this patient? You didn't. So why did you withdraw this support in this? So actually, people think that we do have a statute, but the statute is actually in the context of organ transplant. So because it is recognized by the common law, we still can discontinue life support, but many intensivists do not want to get entangled in all these legal proceedings, and so that is why they continue the life support, and this consumes a very vast amount of resources. Okay, so we have to deal with it, and that is why I use this forum and yesterday's TV to actually say that we have to have a effective communication with the patient surrogates, and we should not be focusing on just the treatment and the interventions. We have to focus on the overall goal of what we are going to achieve for a patient. And we have to avoid mistrust if we actually effectively communicate with the patients and the relatives. This is an algorithmic approach which we supported. We actually designed this this flow chart for we published in the Canadian Journal of Anaesthesia. There are so many other issues. People tend to think that futility is equivalent to euthanasia, because euthanasia is an active process of a physician enhancing the process of death, or being a reason or causative reason for the death. But futility, the physician does nothing. The pathology is actually consuming the patient. We are just standing and watching. We are not actively doing anything to kill the patient or to make the patient die. Now we have to tailor. We have to actually have policy guidelines. And again, as I told you, we cannot just inherit everything from US and all the developed. See that what has happened with McDonald's in a Mexican desert. When they want to have a McDonald's in Mexican desert, and that is where the hut, and then that is how the McDonald's look like in Mexico. Now, are we rationing? Because rationing is one of the concept we have to be very careful about. It should not be confused with rationing. Rationing is allocation of resources to people try to think, oh, when I try to initiate a discussion with a relative that this patient is not doing too well, they come and ask me, oh, you have any other patient waiting out? So that's why you want to pull the plug? So you can put the patient there. I mean, that is the type of mistrust they have. So we should effectively tell them, I mean, we are going to commemorate the centenary of Titanic in 3 days. And always this, when rationing comes, rationing in healthcare comes, they always quote this lifeboat ethics of Titanic. We had, limited resources, limited lifeboats, and we have limited ICU beds. Whom to take in the lifeboats? We can talk for the next 2 weeks about the ethical dimensions of whom should have occupied the lifeboats in Titanic. Okay, I mean, so that is always a controversial topic. Now, again, I was trying to establish one thing is that cost is not only economic cost. This one, when I went to the Washington Social Anthropology Museum, I was so, very curious to see what, benefits and costs of success. Cost is always having a negative, it's not only economic costs. What about the quality of life for the patients? And how about the loss of dignity? I had a 92-year-old lady in the ICU on a pacemaker, and the son refused to accept that the pacemaker is beating. Her heart stopped beating long back, and we had to convince them that it has a big. She was 93. She was demented for the past 5 years, and she had all sorts of electrolyte in the world you can describe. And she had atrial fibrillation, she was on a pacemaker, all organs were, and still the son refused to accept that, even after death, he refused to accept that she died, because he saw something coming up in the monitor. It was actually the pacemaker which was giving the, so that's the loss of dignity. That's the worst way to die. I don't think anybody will like to die that way. Now, what is the value of healthcare? Value is actually quality over the cost. When I go to India, I feel now, there are a lot of corporate hospitals coming up, and they say, oh, bone densitometry, and I have to take the help of Professor Narayan Singh, because he's one of those exceptional academicians. I can't even think of reaching anywhere near at this point. He's still into full-fledged academics, and he will support me that even simple things like mammography has not been well established in all the the benefit of mammography has not been well established, the cost benefits, but forget about mammography. They come out with all bone densitometry, and you have to go and scan your bones whether you have osteoporosis. Nobody does any health technology assessment to see whether these things are really beneficial for the cost it is worth. So when those things are advertised, and that is what they call as a gimmick. Okay, I'm not saying intensive care or critical care is a gimmick, but there are many interventions and screening tests and so many things which are just pushed for the purpose of being, if you go to the conferences, a lot of, they want to come out with, I have this latest technology anesthesia machine, I have the latest technology mechanical ventilator. Whether it has changed outcomes, nobody has tested it. No health technology assessment. But just because they put in another software, they want to increase the the price of it, and that is how they sell it. So there's a lot of industry push. And so if you see the value of intensive care, this one, the outcome is here from poor to good, and the cost goes up. For the same type of outcome in TNT, Barbados, UK, and USA, you can see how the costs go up. This is by the same prognostic models which they did, we did actually, and there are studies in the critical care journals. Many of the public hospitals in the developing world, Africa and India, they all lie here, somewhere here, because the outcome is also poor and the cost is also poor. But here our outcomes are reasonably good according to the prognostic models, but our costs are reasonably good, and this is where probably the health ministry will come for a health tourism now. Now, this this is called a Kindig's curve. Actually, see, we invest so much of money and how much units of health we gain from the money. At one point of time we gain, and it just plateaus, and at one point of time it even goes down. So further investment is going to reduce the quality of health. So we always think that high cost healthcare is high quality healthcare, which is not true. That is what I want to tell you. Now, that is for the futility, and the last part of it is, as I told you, and I want to just establish this one about the roles of anesthesiologists and the public image of anesthesiologists. I want to draw a little analogy. I play the tabla, and as you see that I play the tabla, and they have kindly considered they are here now. This is the 60th anniversary, wedding anniversary. I play the tabla now. Now, the tabla player and the anesthetist are almost very similar. I am going to draw an analogy. People don't come to listen tabla. They come to see, who is singing. So the patients come for a surgeon and not for the anesthesiologist. And the tabla player is always seen as a sidekick for this main singer. And we are seeing, unless you are somebody like exceptionally good Zakir Hussain, who came last month here. He can play solo. People come for him. They don't bother about who is singing. He's exceptionally good. Okay, but to be honest, I have last time when I went to a concert in this one, I cannot, as an anesthesiologist, I cannot expect every time surgeons of the caliber of Professor Narayan Singh or Professor Ram Sevak to come and ask me that, you anesthetize my patient. I have to face some surgeons who, same way, when I went to Tabla last time, before we could start with the best singer, a lady came. Can you play tabla for me? Okay, I said, okay, fine. Anyway, I am a sidekick, I'll play. Right. She didn't have a clue about how to sing. And I have to do the same thing. I have to operate with surgeon who doesn't have a clue of what he's doing or she is doing. So that's why I want to draw an analogy between tabla and anesthesia. And based on this, actually, the public image of anesthesia, we actually published a paper on patient perception of the role of anesthesiologist. And to be honest, it's very poor, very, very poor. And I'm telling my students, please boost the image of anesthesiologists. We have plenty of roles in this hospital and the community. So that is actually, many people did not even know that we manage intensive care unit, and we are involved in other areas in the hospital. And the Mexican Federation actually asked me to write a review on the same topic on, how patients and the other healthcare professionals, value anesthesiologists. And I wanted to say that, the pain relief is one of our major things of anesthesiologists. They call the pain specialist as algologists. So, we get involved in patient, pain relief. So, we publish a paper. I do a lot of research on pain relief. And we actually, me and Dr. Chen used to go to World Congress of Pain and publish and present all our research. And we have, we have papers in ethics too. As I told you, we have to have a contextual approach towards ethics, and I wrote articles on that. Now, the final part of it is, the technology is coming so much into our life. I don't know whether this boy doesn't have even a cloth to wear, but I'll not be surprised if he's on Facebook. And you can see that, they don't want even waste time in the, they are. So the technology is so much into our life, and my children cannot cannot stay at home without iPads for 10 minutes. iPad is not there. Daddy, I am bored. Yeah. So that is how the technology is influencing us. You can see that the evolution diagram itself changed now. How we are going back to the computer world now. And I don't know how many of you read about the Bluffer's Guide to Doctors. There is a Bluffer's Guide to every profession. There is a Bluffer's Guide to Doctors, and they describe that ICU ambience. If you see this, for the uninitiated person who walks into a ICU will be like walking into NASA. Okay, that is exactly what they describe in the Bluffer's Guide to Doctors. Now, why I am saying all this is that we lost the humane touch in medicine. I'm sorry to say that. I wrote this in my article about the medical science and humanities, and I actually, I'm a very ardent supporter of technology and technological advance, but still I'm a very, I'm very passionate that, all our students, I tell, even though it is not part of my curriculum, I tell my students that, how you have to establish a rapport with the patient as a doctor, because it's actually the patient and the doctor, two human beings. We have to establish some sort of a rapport, and that is what is needed actually, and the machines and the software should be only a secondary aid in patient care. And this was actually, this is shared by another doctor from, actually this, I don't know how many of you know about, he's an author, Abraham Verghese. He migrated from Kerala to actually Stanford. He is a theoretical medicine, professor of theoretical medicine in Stanford. And he said entering medicine was a passionate quest, a romantic pursuit, a spiritual calling, and a privileged yet hazardous undertaking. This is his recent book, Cutting for Stone. If you all get a chance, you could read about the other aspect of medicine. He's a very good author, actually. His earlier book was, My Own Country, about HIV. I read that book, and that opened my eyes about HIV. Now he says it's a view of medicine. I don't think too many young people in the Western countries realize that. Frankly, in the sterile hallways of modern medical industrial complexes, and that is what he describes the hospital, which I thought, somebody thinks exactly, where physicians and nurses are hunkered down behind computer monitors, and patients are whisked off here and there for this test and that test. That side of medicine is lost. And that is exactly, I actually, even though it is not part of my curriculum in anesthesia, I try to talk to the undergrad students. I tell them, please practice ethical medicine. So the take-home message is for all of you is, I wanted to tell you that death in ICU alone cannot be a real performance metric of a unit, and more importantly, the application of life support to prolong the process of death in an intensive care unit is really inappropriate, which we are doing now. We have to do something about that, and the general population should understand the reality of death and accept nature. Thank you and namaskar. Sorry, I have to adjust that.
And now for also.
You could have this.